Okay. I think we should be live now. So welcome everybody, and thank you for tuning in for another research discussion with Open Digital Health. My name is Sebastian Potthoff, and I'm one of the directors of Open Digital Health. It's really nice to see everybody. So if you have joined this event by receiving a kind of a calendar invite or an email or a referral from a friend, that's great. Another way that you can hear about these events in the future is to sign up to our website as a member, and we will send you some newsletters and notifications about all of the upcoming events, our mentoring program, and some of the other things that we have going on. So if you haven't subscribed as a member yet, that's definitely something I would suggest you do. But now I would like to move on to today's event, and it's my absolute pleasure to introduce you to Dr. Robab Abdulkhani, who is also one of our national leaders of Open Digital Health. So it's even better to see one of them presenting. She's a postdoctoral researcher at RMIT University in Australia, and is actually joining us from Melbourne, and it's quite late for her at 7 p.m. So that's definitely something we should thank her for. In this webinar, she will be talking about the data quality of connected wearable devices used in remote patient monitoring. She developed a data quality management guideline in her PhD that guides the stakeholders on how to design a remote monitoring service that enables data collection, management, and use of high-quality data to drive accurate clinical decision-making and improve patient outcomes. So yeah, at this point, I will hand it over to Robab. Take it away.
Oh, thank you, Sebastian, and good morning, good afternoon, good evening to everyone who's joining us from different spots of this planet. And thanks to Open Digital Health for the invitation to present at this webinar. As Sebastian said, I'm Robab Abdulkhani, a research fellow at RMIT University in Australia. For those of you who wonder what it stands for, it's Royal Melbourne Institute of Technology. I'm also privileged to be one of the national leaders and Australia's representative in this new international Open Digital Health organization. What I'll be talking about today is the output of my PhD that was completed last year at the University of Melbourne. It's about connecting wearables to healthcare through a guideline for the quality management of patient-generated health data. Just in terms of housekeeping, as I already shared my screen, I won't be able to see your comments or questions. And to be honest, I'm not good at multitasking at all. So we have Sebastian here, who kindly will facilitate the session tonight. And he will interrupt me if there is any tech issue or anyone has any question or any point on particular slide. We also keep a couple of minutes at the end for discussion. So if that's all good with everyone, I jump into the main topic. As you see, the project comprised 4 key components. It developed a guideline to say how the quality of patient-generated data collected from health wearables can be managed in remote patient monitoring initiatives so that this data can be reliably used for patient care and be incorporated into routine clinical practice. To clarify at the beginning, let's say that different people might have different understanding of data quality. In this session, I won't talk about how to measure the accuracy of algorithms embedded in the wearable design or how to develop a wearable platform. Rather, it focused on data quality management concept from health information management perspective, which means looking at data quality across all data management stages from collection to use for decision making. Also, I want to note that the scope of this project was limited to the quality evaluation for use of PGHD in patient care as primary use, and not about the secondary uses, for example, like for surveillance or for financial purposes, etc. I want to briefly explain each of these components. PGHD refers to any type of health-related data, such as health and treatment history, symptoms, biometric data, lifestyle choices, and other health information that's created, recorded, gathered, or inferred by patients or from them or their caregivers to help address a health concern. Today, the explosion of connected health tools market, including both medical grade and consumer grade wearables and their associated tools such as mobile applications and web portals, is really helping in high production of PGHD. Remote patient monitoring initiatives are one of the solutions to help bridge the gap between PGHD, wearables, and healthcare industry, and bring these tools and data to patient care. The point is that although RPM was primarily used to manage chronic conditions, the COVID-19 pandemic is already accelerating the use of these initiatives to treat mild cases of the disease, as all of you have already noticed that. And RPM will continue to play an important role during and probably after the pandemic. But the successful implementation and use of these initiatives relies on high quality data and efficient data collection and management processes. But what's the current situation of remote monitoring, and to what extent it considers the quality of this data, and what's the role of that quality management in these programs? How the quality of PGHD might contribute to the safety and to the quality of care in this intervention to help in integrating this source of data into clinical workflows. So we try to answer these questions through this project. This is an example of a daily life of a diabetic person that we called him Steve here, when uses a wearable and communicates the data with clinicians for his diabetes management. As you see, Steve uses insulin pump with a receiver to adjust his insulin dose, as well as a continuous glucose monitoring or CGM that connects to a mobile app and gives real-time information and alarms on the blood sugar. Also, he gets weekly or monthly reports on a patient portal that he can share with his clinicians. He also writes down his activity and meals on a diary. He uses a glucometer a couple of times a day to calibrate his CGM. And as you see, he's wearing a fitness tracker to monitor his activity and heart rate and other data. So although some of these devices work automatically to monitor his status on a daily basis, he needs to be careful on doing the calibration, taking notes, changing sensor, injecting insulin, and all this sort of stuff, which might impact his safety and even the quality of his health monitoring. So what should actually we need to care about the quality? First is that the person, or in some population who are too young, or for some elderly people, the caregivers are the main people who supervise this data collection. And that happens outside the clinical setting, and it's not controlled environment. And the third is that these people might choose to share it with others, or some hackers can easily connect to these devices and get access to them. And last is that we don't have any guideline to say that whether we need to measure the quality of this data. So this picture simply shows how remote monitoring scenarios work in Steve's case and other cases that use wearables for monitoring different diseases. Data might be collected manually or automatically and stored in an app or portal that's mainly administered by the vendor of that wearable. Then, based on the predefined protocols for the remote monitoring intervention, the a person brings the report to the clinic, or they must share it remotely between visits via emails or phone calls. At the clinician side, when they review and make a decision, that report that usually comes as a PDF file, it's saved somewhere, as a folder in clinician computer and not being further analyzed or stored in the EMR. And this process of data management was similar in different remote monitoring that applied for different conditions. I examined 3 case studies of diabetes, cardiac arrhythmia, and sleep disorders. So now that you see the overall picture of remote monitoring, to what extent the clinician would consider the quality across the collection stage to transmission to review? And what do we exactly mean by quality? It's actually about whether the data are complete, accurate, understandable, accessible when needed, and relevant to that condition, and how all of these might impact the safety and quality of that intervention. Some clinicians must say that quality isn't that much important because they're happy with the report and its graphs and charts. It gives them the sense of what was going on and it transfers that main message for decision making. Some may say that they trust the device because it's already regulated in terms of accuracy, but by those regulatory agencies. But quality isn't actually limited to accuracy, nor the device itself. And here in this slide, we show why. There are other issues that might impact the quality of PGHD. First is the behavioral issues around the person himself, the family members or caregivers. As I already mentioned, this actually happens outside the clinical setting. The other one is the process in which data are transmitted and the technology. If still remote monitoring seems to be okay in terms of quality, but considering these issues, so we still can see that these interventions are limited to one of short-term studies on small scale and not incorporated into the routine clinical practice in so many cases. And why still we don't have any guidelines that specifically talks about PGHD quality if we one day would consider this data as an important source for patient care. Whereas we have established data quality management guideline used within healthcare settings for the clinical data. So in this project, I tended to understand first how data are managed in remote monitoring, how the quality is monitored during data management, and what socio-technical issues might impact them. And through this, we came up with a guideline for 7 aspects of data quality. I briefly want to say that what was our methodology. There wasn't a systematic method to define guideline development in health informatics discipline. So we had to follow the existing principles for clinical guidelines, but adjust them to the multidisciplinary nature of digital health and health informatics in this project, and make sure that it involves different stakeholders. I'm not going to explain each stage in detail, but all of them are already published in peer-reviewed journal publications, and you can find them through my Google Scholar profile. We first started with the literature review and finding the gap, and then we did interviews with international stakeholders. And what I mean by stakeholders is that everyone who was directly or indirectly involved in remote monitoring. And in the next slide, I will explain that who we found there. And it actually came through the snowballing to understand that who are really in that team and how they can help us to find some others. After finding the challenges that these different groups of stakeholders had in the current remote patient monitoring programs, then we brought them and other stakeholders into co-design workshop to understand that what kind of strategies we can design to overcome those challenges. And then findings from these 3 stages, we synthesized the finding and documented the guideline itself with set of recommendations. The last stage was to validate this through an international survey to understand the extent to which they can provide safe and quality care. These are the findings of the interview stage. In this process, I found that none of the RPM programs was fully integrated into the EMR or clinical workflows. The RPM team also include patients and their caregivers, clinicians, including specialists and nurse, and the representative from the wearable vendor to provide IT support. This team looks sufficient for managing, a project-based remote monitoring that conducted as a one-off study on small scale. But if we want to go further than that, and if we want to think about integrating PGHD and RPM into EMRs, the team needs to be expanded. One point is that theoretically, the new methods and tools for health data management are changing the landscape of patient care and blurring the defined bodies of knowledge in health information management and health informatics. Although this topic is an example to merge knowledge from both fields, we realize that none of the health informatics or even health information management professionals are actively involved in these programs, neither the administrative, payer, service managers, or consultants. However, we found challenges in that quality, even in these small projects that require expertise other than these three members. For example, data needed to be cleaned, analyzed, and processed to provide meaningful insights for clinicians. We found that nurses were filling this gap between the patient and the specialist, but they lacked knowledge and they lacked expertise on how to work with wearables and their reports. And this is a summary of the workshop study. Given that the scope of the study was limited to the quality assurance of primary care of data, primary use of data, and not other uses, we picked up 4 main groups of stakeholders. So in addition to the 3 that already exist, we added those health information experts to understand their needs and co-design strategies in order to be able to collect and manage high quality data, integrate them with the clinical workflows. You see, they expressed what they want from other groups in order to be able to collect and manage high quality data themselves. So all the details of each of these items are already published in a separate paper if you want to refer to them. Now let's move on to the data quality dimensions. So we're gonna explain the 7 dimensions and what we found as challenge and what the guideline would suggest. I'm starting with the accuracy. It's defined in this project as when data are free from errors. The first thing was about device calibration. Some wearables needed one-off calibration before starting data, but can we really ensure they work correctly in the entire data collection period? Some others required calibration a couple of times a day throughout the data collection. But even for those devices, I found that the advices on how often and when exactly to calibrate isn't based on clinical standards of care. Usually patients get what's recommended by the wearable vendor on their website, but few clinicians who seem to work in these programs for a long time, they disagreed and wanted this to be based on clinical advice. Also, it's still taken manually, which might be erroneous. So this guideline suggests that calibration can be done automatically to whatever possible and be based on the standards of care. Also, some of the PGHD elements, such as meals and mood, still need to be entered manually, which might not be accurately captured and people might forget to add them. But for those of data who can be collected automatically from consumer wearables, such as fitness trackers, and the data can be activity, heart rate, and other general wellness data. Why should the patient still need to enter them manually into the medical wearables? Because we found that there is no mechanism exists at the moment to connect consumer and medical wearables and allow this flow of data among them. The third item is annotation of either manual or automatic entries, which is absent in most wearable platforms, and would help to correct some inaccurate data immediately after collection. The other one is accessibility. Some wearables are blinded and don't show raw or processed data to the patient or to the clinician during data collection. Some are deliberately disabled because of some clinical purposes, but interestingly, the same devices show data to the patient at data collection in other cases of the same disease. This is what we found. Some recent studies showed that new generation of wearables that let patients access their data once they capture them would really engage them in their health and help in changing their behavior if needed, and to move from being passive users to active participants and engage in remote monitoring of their health. And the same with the clinicians. Some wanted to get access not only to the processed data in the report, but also to the raw data to find out more details. The second one is getting routine notification on PGHD access by others, which highly depends on defining the ownership principles about PGHD. This might be more suitable to the patient, actually. And the third is dynamic consent. Most patients were not satisfied with the single click on the terms and conditions or the consent that they get from the clinic, but rather dynamic consent for different levels of access to their data in different stages. The other aspect is timeliness, which focuses on the time of accessing data. We still don't have protocol to define data availability on ongoing or periodic basis in remote monitoring of even one type of disease. For example, some wearables of the same type are blinded. Some others show data during data collection. Some clinicians can only get the report at the clinic, some get it remotely. I found some people don't even call it remote monitoring because there is no remote interaction with the patient. Whereas some clinicians reported if there would be a mechanism to share data in real time or in near real time, they would notice some issues and identify the causing habits and behaviors, rather than relying on patients' notes that might be forgotten and come after a couple of weeks. The other one is consistency. Still, most PGHD, whether in consumer or medical wearables, don't have clinically accepted definitions or standardized format. Each wearable has its own way of data presentation. So can we really make sure that the clinicians who get different PGHD from different types of wearable platform will understand all the reports? Or should clinicians limit patients to use only one specific brand of wearables that they are familiar with? What we need to do, which might be impossible for clinicians. And they themselves actually prefer giving patients the authorities on choosing their own favorite device. But they are also concerned that over time, that people use different brands, they would expect clinicians help them in interpreting the report, while clinicians can't cope with these changes. The second is integration with EMRs, that if this would really happen, would change lots of things. PGHD could be captured from any type of device, could be filtered, cleaned and analyzed to extract meaningful information for shared decision making. And the last one, which is still challenging even for clinical data, So if PGHD would be considered as a valuable source, should be treated similarly, and we need to think about consistent exchange of this data. Interpretability. Actually, interpretability and consistency concepts have lots of overlaps. This item was the most dominant issue reflected in all of those 5 stages that I already mentioned in the methodology. The patient-clinician interaction will, in the future, become less about gathering PGHD and more about interpreting what that PGHD means for the individual. First, all PGHD lack metadata or contextual data to inform the clinician what the patient was doing at the moment of data collection that caused, that up and down in the trend. Also, some devices enable the patients to take some notes, but it would be better to capture them in a more systematic way through interaction with the patient. Also, only few wearables give alarm on the out of normal range data. Not all of the patients are highly literate to understand the out of normal range for example, heart rate. And what would happen for them if that occurs? A clinical advice can be attached to that alarm to improve patients' awareness. Also, most current wearables provide snapshots as a PDF and maybe show interactive visualization through patient portal, but only to the patient and not to the clinician. But clinician really might need to go deeply through that report and customize it and do some more functions. So we recommend that this interactive visualization be available for both patients and clinicians. Completeness. The main reason for repeating data collection is incomplete data in that report. Sometimes the device doesn't work properly. Sometimes the patient takes it off because of lack of motivation or because of being a burden or so many other issues. But what can we do to avoid that? If there would be a predefined protocol to specify some downtimes during a day based on clinical standards, and then resuming data collection to make sure that sufficient data could be collected to make a decision based on that. Also, annotation functionality that I already mentioned in the accuracy slide would help to report the reason for missing data to find out the solution for that. And relevancy. Apparently, data relevancy doesn't need more explanations, but the findings show that some relevant data aren't yet defined in the wearable design. Also, not all the dots, captured that are relevant. So clinicians have to spend time to find out the most important information through that report. So we really need to think about that as well. Going back to the point I addressed at the beginning of the presentation, that different people look at data quality differently. Some might focus on the review stage and try to design some dashboards where PGHD from different tools come together and filtered and analyzed there. Some would bring the quality to the collection point and engage people from the very beginning. This is another snapshot to show which aspects require more consideration during each stage of PGHD management, that we categorize them based on the overall stages of collection, transfer, and review. As you see, as PGHD is collected outside the clinical setting, under the patient or caregiver's supervision, it needs more concentration in terms of quality assurance. And the rest of them, need attention at the transfer and the review stages as well. So the key takeaways, what you can take from this presentation. The guideline by itself wouldn't be efficient if none of these 4 elements exist. While remote monitoring certainly has value to offer to healthcare system, there are really multiple obstacles to consider and overcome to get the most benefit out of these technologies. We need more policies in terms of reimbursement models, human resources to expand the team, more regulations, especially for consumer wearables. Also a robust technical infrastructure to seamlessly incorporate this data into the clinical workflows. All PGHD stakeholders, not only patients and clinicians, need digital health literacy. And the last but not least is the collaboration. Remote monitoring mostly work in silos, and that's a big challenge. Different groups, stakeholders don't communicate with each other to understand the needs and requirements. We found that these people really need to understand each other's expectations and need and find out collaborative ways to be able to co-design the remote monitoring service together and then start developing and how to pick up the technologies that can be responsive to different needs. At the moment, remote monitoring are only used for one specific disease. But in the future, we might shift towards something that's more human-centric, when a person suffering from multiple conditions would really need to recruit in a couple of remote monitoring, and that would be a huge burden if they need to manage different devices for monitoring different disease, but it's only one person. So if you want to move toward that and design remote monitoring for multi-morbidities, we need to think about these ways of collaboration even more carefully. So this is the end of this presentation, and thank you very much for listening, and now I open it for discussion.
Thank you very much, Robab, for the super insightful presentation. Really lovely quality criteria, very clear, very nice co-produced work. Really interesting to hear about this. Yeah, like Robab said, we open it up to questions at this point, discussion, any thoughts, feedback. You're welcome to unmute yourself or put your hand up, and then, yeah, actually we're quite a few people. So if you could put your hand up or post your questions in the chat, then that's how we can get the discussion started. Okay, while we're waiting for the first question to come in, I was wondering, Robab, the clinicians and stakeholders that you have worked with to generate these guidelines, was it, did it have to do with any specific clinical area? I know you talked about type 1 diabetes. Were they all working in that area, or were there different examples of kind of health related generated health data?
Yeah, I brought one example for diabetes because it was the most complicated case, but we also covered people suffering from sleep disorders as well as the cardiac arrhythmia to understand how remote monitoring is working in chronic conditions, and that all happened before the pandemic. So we didn't get the chance to understand that how it's working during the pandemic, but we all see that this, COVID-19 pandemic is really bringing that opportunity to learn more about remote monitoring because it has been rapidly implemented around the world. But we still see that how important it is to think about the quality because it just was implemented as I saw here around, but without, having that systematic approach on how to redesign some systems or how do we need to probably think about co-designing it from the very beginning.
Great, yeah. And was there any clinical area where you thought there was like a sort of an example of a best practice where it's been most integrated and sort of where it worked reasonably well? Was there anything that stood out?
Yeah, I think if you want to compare the three of them that I worked on, diabetes was a bit better because the devices that have been used for diabetes type 1, especially the government has subsidized them for diabetic type 1 in 2017. And therefore, more people got access to more devices. And that actually was encouraging people for more self-management. But the concern at the clinical side was that how we would engage people to come to us and let us know how they use these devices if they really need clinical advice, because it seems that people get it and start using it and get the the tutorials from the vendor websites and not communicating well. And even if they want to communicate, actually, it's only limited to very short clinic visits and not that comprehensive process that we would look at from health informatics point of view that comes to the EMR, and some people would do more analysis. And usually we see in a very fancy way that clinicians get access remotely and they can give advice to the patient. No, none of this was happening on those cases that I worked on.
Thank you. We have a couple of questions. I'm going to start with a question in the chat here. This is from Dominika, and she says, fantastic talk and thank you. So where do you think is the future of wearable heading? Do we need more regulations, or the opposite? Shall we encourage open market, innovation and competition?
Great question, Dom. Yes, and I totally agree that the shift is toward policies and toward regulations, because we've already got that rapidly growing market of wearables, and we see that imbalance between the production and the actual use in practice, and that transformation into the existing models. We're trying to fit into this, bring these technologies and fit them into the existing models, whereas this is not working. We need to define new models that can embrace these technologies, find a way for them, define the workflows that can get these, and try to upskill the people who are working with these devices into the workflow. Try to define that how they're going to reimburse for the time that they will spend for reviewing data. One of the things that we found that most clinicians aren't interested is that they say, if I want to, I only got 15 minutes for that clinic visit. If I want to spend time on reading that report, understanding the data and the graph, which is really complicated because they already, haven't got any training about how to read and understand and interpret those reports, who's going to reimburse me for this time that I'm spending? Because my primary, mission is to spend this time for a consultation and things like that. So we definitely need to, think about how to work on and think about how to regulate more devices. Again, I mentioned that having regulation by itself isn't enough to make sure that these devices would properly work, or people would engage actively, or even clinicians would engage. In terms of the organizational point of view and in terms of the policies, we need those movements.
Thank you very much.
I hope this answers your question, Don.
Yes, hopefully. I think she might be connecting from her phone, but so I take the next question from Aminul Islam. If you want to unmute yourself and ask your question or your discussion point.
Thank you for excellent presentation. Can you hear me?
Yes.
Yes, we do.
Okay, thank you. So Rawab, thank you for your excellent presentation. I am from Bangladesh. My name is Aminul Islam. I'm assistant professor, Department of Health Informatics, Bangladesh University of Health Sciences. So I have actually two questions. Could you please allow me two questions? Is it possible?
Go ahead.
So number one question is that you already mentioned that devices need regulations, but currently, basically, I'm searching for some IoT device for my remote monitoring and some maternal care project. But I'm struggling to find, which wearable is giving me the right data, the quality data. So I'm really puzzled here. So I cannot basically decide, because there are so many devices, so many companies in the market. It is very struggling. So if you guide me, so regarding the selection of the device, what should I basically measure, or what should I look after? And then my second question is, which I did not find in your presentation, that data privacy and the security, basically, since the remote monitoring and the wearable device, so it's connected through the Wi-Fi device and the internet. So how can we basically ensure the data will be protected and secured through this, basically from remote sensor to my server or my applications? Thank you.
That's great, thank you. I'm trying to answer both of them. The first is that the guideline was developed to answer this kind of questions, that among all these various technologies, and all of them are trying to compete with each other to provide more features, to be more user-friendly, which one I can rely on for that service that I wanna run. So that's why we're providing this recommendation to say that if you want this data to be accurate, you need to think about this. But these are very high level recommendations. So for different contexts, for different diseases, and for different technologies, they can be adopted with more discussions with the stakeholders, different sessions and brainstorming, that if we want to consider these elements for the accuracy part or for the consistency or for that, how we're going to design our workflows, that this type of technology would help. It actually requires developing a checklist to understand that for this service from the very beginning, how can I do this? And then evaluating those technologies, that which one is actually meeting the requirements that we have, and then thinking about the end of it, what we're going to have after finishing this implementation, how we're going to evaluate this. And again, the quality would come in here, that if we want to make sure that we want to get high quality data, we need to think about the end from the very beginning. In terms of the second question, accessibility is actually one of the dimensions of data quality, that the time doesn't allow us to provide much more details and discussions, because I think that each one of these dimensions can itself be a project and be explored from very different aspects. So I didn't look in very detail on each device cybersecurity issues or things like that, but we came through very overall recommendations in terms of dynamic consent, in terms of ownership and things like that. So if you want to understand that whether your patients, based on their clinical needs, need to get access to their data during data collection, or clinicians, then you need to pick up a device that has that ability, and it doesn't have any problem with the clinical standards that patients see their data during that. But obviously those devices who cannot provide that feature might not be suitable for that. But I'm more than happy to have another complete discussion with you about this. If you would like.
Yeah. I'm thinking it's a serious discussion. The topic is not, is a very time constraint here, I think. Thank you for your answer.
Thank you.
Thank you, Aminul. That was a really good question, I think, around sort of implementation of these criteria guidelines. It's a really good question, sort of like who are they for, and how can different stakeholders benefit from them. So I think that's a really good point. Do we have more questions? Anybody else? Let me have a look at the chat. Okay, so there's something here in the chat by Reza. Great presentation. Question: can wearable data be shared anonymously with clinicians? Any approach to mask data disclosure, or let patient users to share what they want, or a trusted third party to monitor before sharing?
Good question, Reza, and thanks for coming to this webinar. So, we already have that third party, and they are the main controller of remote monitoring at the moment. So healthcare system actually is not that much involved, as I said. It's only between clinician, patient, and that third party, and it's not, integrated. It's not going into the EMRs to apply the privacy rules set by healthcare systems or the government for those. So everything is just controlled basically by that third party, and they can determine whether people share or can get access or send data anonymously or all this stuff. But I have seen in some platforms that people can find and can actually add the other people in addition to the clinicians to get access to their data. And specifically that was designed for diabetes monitoring. So very complicated, more advanced wearables are coming into the market that can address those privacy issues, and some are not. So again, depending on what the healthcare system would design when they start developing a remote monitoring in terms of privacy, and those features might be embedded into designing that platform, into a device, into the mobile application that comes with that device, or as a consent that they would start at the very beginning. So it all comes into that discussion between the stakeholders, that how they want to address that. We cannot at this moment say that this device with this feature is the best one to address this. Usually devices can come with any feature. We can design anything we want to have in those technologies, but it depends on that context and the purpose of remote monitoring.
Great. Thank you, Reza. I hope that answered the question as well. Are there any further questions for Robab? Don't see any hands right now. Oh, there's a new, okay, yeah, it seems to have answered the question. Before we close it then, I have a question. So where are you going to go next with this research? You're a postdoc now, and I'm just wondering, are you continuing to work with these guidelines? Are you hoping to focus perhaps on specific ones of them, or maybe use them to assess existing tools and the quality of them? What are the next steps in this endeavor?
Oh, great question. And I really thank you for bringing this stuff. So the interesting thing with digital health is about linking and connecting. It's a multidisciplinary field, and it was supposed to be something that links different contexts to each other, rather than working itself in silos. So I brought this to my current work to understand that how remote monitoring is working in nursing, and how we can develop a nurse-led remote monitoring, and to highlight the competencies that nurses require. Because as the largest group of healthcare providers, nurses really need to be more literate in terms of engaging. And the COVID-19 actually showed, and we just published a literature review about that, about the extent of telehealth services and the lack of competencies among nurses on how to be engaged when they use remote monitoring and virtual care and video conference technologies when they want to interact with people remotely. And also, this guideline has been developed, but hasn't yet been implemented. This is what I'm doing, to presenting to different people, to show, and raise that awareness that, look, remote monitoring packages are already in the market, and, researchers can bring them and do research about them. Healthcare providers can bring them and implement them and use them. But we need just to say that, let's think about this more broadly, where we were going to go with that remote monitoring, because we just see that they are really on a very, very short-term basis, and they're just defined as a research project, and we don't know what's going to happen after that, whereas that person has this disease forever, especially the chronic conditions. So we need to think about this more systematically. I'm showing this, I'm presenting to see if anyone is interested to implement, or they are at the implementation stage, or they want to design something how they want to implement it and how I can help them with these guidelines. It's not one size fits all approach, and it's not something that we can say it's detailed for different diseases. It's very high level recommendations, but through working more based on that specific context that we have and based on those clinical questions for different diseases, we can work to adopt these, to define some more protocols for each one of these stages. So I'm happy to help anyone who wants to use this, for their remote monitoring programs.
That's great. It sounds like there's a lot of opportunity there for future research, like you said, to tailor to specific contexts and conditions. And yeah, so it sounds like a very fascinating project. So if anybody's interested, get in touch with Robab. And also Robab, if you have any sort of like publications that you were mentioning, feel free to send them to me and I can share them together with a recording of today's event. So thanks again for this. Before everybody's off, can I just ask, I put a link into the chat just now. If you could just take 2 minutes to give us a little evaluation of today's event and help us improve future events, that would be highly appreciated. It really just takes 2 minutes. So thanks again, Robab, for the presentation, and thanks everyone for coming along. Don't forget to subscribe to our website for newsletter and future event notifications. And then I look forward to seeing everybody during the next event. Have a good day.
Excellent. Thank you, Sebastian. Thanks everyone for coming.
Thank you. Bye.
Thanks, everyone. Bye.